My name is Dr. Allen Honigman. I'm a periodontist out in Arizona, which it's very hot here right now, unless you're a baked potato. I originally got my training in San Antonio, Texas, and I finished my dental degree in 1991. And I went on to UCLA to finish my periodontal training there, and I finished there in 1993. And prior to that, I received a Bachelor of Science in Biochemistry and a Master of Science in Immunology, and just kept going, and here I am now treating periodontal disease with beam of light and enjoying it quite a bit. I've trained at, I was the clinical director at Case Western Reserve University in the perio department for a couple of years before I moved to Arizona, and here I am now. I've had a private practice since 2003, and I've enjoyed every bit of it so far, especially since I started doing LANAP. So I think we'll get started right now and move on to the next slide. And one thing I like to say is there are no bad teeth, just bad owners. Our teeth aren't necessarily our problem, but how we take care of them, how our patients take care of them is a problem. So it's up to us to try to do something about making sure patients maintain their teeth for hopefully their whole life. One thing I've noticed is I have very few patients come into my practice asking for what I call the picket fence. No one likes to have their gums cut, and I did for a long time, almost 14 years or so. Traditional gum surgery, it works, but there is a cost to it, and it's usually an aesthetic cost and a cost in terms of sensitivity and just not very pleasant to look at or pleasant to work with. The slide you see now, the patient is functional. They close, they do whatever they want to, but the pocket depths are maintainable, but there is a cost involved. And if we look at this slide here, let's go back one. If we look at the first slide, at this slide right here, you can see there is a cost. Functionally, he's fine, but aesthetically, I don't know if I could ever do this to a patient ever. I was taught at UCLA never to do a surgery on the maxillary anterior 6. That's the golden area. So, the best we could do was try to maintain any deep pockets and do the best we could do because we didn't want to ruin any aesthetics that were in the area. What I like to say is, and actually what Millennium likes to say, is we want to affect it. We don't want to resect it. If we can take care of the problem at the bacteriological level and to just get rid of the tissue that we actually need, that would be the way to go instead of just amputating everything away just to try to get the pockets down to more maintainable levels. If we look at this slide here, you can see this patient has a traditional type of granuloma, and maybe it's a peripheral granuloma or a pyogenic granuloma. In most offices, we would just remove that gum tissue, send it off for biopsy, and unfortunately, we may leave the patient with a severe aesthetic problem. In this case, what we did was we did LANAP on this patient because he needed it anyway, and we went ahead, just treated it once with our LANAP protocol in the PerioLase MVP7. And what you can see here now, this is after now about probably a week of healing, you can see now how much it's shrunk. Is it completely gone? No, but we'll let this heal in and see what happens with it. If it doesn't go away completely, now if I have to resect any areas, it'll be a much smaller area, a much less aesthetic problem in the future for the patient. Here's another patient here. You can see here a pyogenic granuloma possibly. If we went ahead and tried to resect this off just to set it off for biopsy, you can see the potential problem you would have with the papilla, with the root exposure, etc. And again, why not just affect the tissue, see what happens with it, and then make our decisions from there. But let's see if we can get it down first. So here's the patient about a week later. You can see now how much that tissue has gone down. We've just gotten rid of the bacteria in the area. Let the tissue kind of do what it wants to do. What it needs to do is just heal in. And now we see the patient about 4 weeks later, and now you can see how small that is. We've retained the aesthetics very nicely, and this just continues to get smaller and smaller. And if I have to remove it, now it's a much smaller, more aesthetic type of removal rather than trying to cover this up with a connective tissue graft or another procedure. So if we can affect it rather than resect it, the patient's better off, my restoring dentists are better off, and I feel much happier about treating patients. The patient you see in front of you now, you can tell from the probing depths, this patient has some severe periodontal problems. You can see he's got a lot of 14s, 9s, 6s. I pick a number, he probably has it. In a traditional periodontal office, this would probably be a extraction case, possibly implants. It would be a lot of heroics going on here to try to save this patient's teeth. If we look at the pre-op picture, though, I mean, he still has a lot of gingiva left. He still has, the aesthetics aren't that bad. They're not great, but he still wants to keep his teeth. In a traditional periodontal situation, if this was, I've been doing LANAP for about almost 4 years now. If this was 5 years ago or 4.5 years ago, I wouldn't have given this patient a lot of hope. Maybe some scaling and replaying just for maintenance, but we all know that that's just a downhill slide to dentures or implants. So we went ahead, we treatment planned him for LANAP, and he was happy that at least we're giving an option. Worst case scenario, he may lose his teeth, but we're going to give him an option, but I think we're going to keep him. Here's what he looks like the day of the surgery. What we did was we splinted his front teeth together because they were loose. Whenever we get a broken arm or if we break our arm, the doctor doesn't just let it flop around. Tissue and bone need stability to heal. So we want to stabilize the teeth to give the tissue and the underlying bone a chance to gain a new attachment back to the teeth, back to the root surface. We went ahead, we did LANAP on him, and in this case, I've been doing it for a while now, so I understand tissue interaction and how to keep the speed up, and now I can go ahead and do a full mouth procedure in one appointment, which is much nicer than trying to do traditional surgery, which may take 2, 3, 4 surgical appointments to get done, and waiting in between each one for the patient to feel better. This is what the patient looked like immediately after we finished LANAP. What you're looking at here is not only the splinting, but you're also looking at the blood clot, our biological seal, our nice biological bandage. This is what is keeping our gingival epithelium from going down and growing into the pocket, giving us a long junction epithelium. We're looking for here, now we're blocking it out with this to be able to get a nice new connective tissue attachment. And this is what I'm looking at here. You can see the nice blood clot in the area, nice, beautiful biological seal. Here's what the patient looked like a week later. This is 1 week post-LANAP. You can see here, look at the tissue now. If you look at this tissue, you can see how nice and pink it is. It's much less inflamed. And the other thing I want you to notice is we really have not lost any significant amount of tissue. We haven't had any recession, which you would normally have with any type of resective procedure. So we've maintained his situation. He doesn't have any more sensitivity than he had when he started, etc. So this is a very nice tissue-sparing type of procedure. Here's what the patient looked like at 4 weeks after LANAP. Again, now what we're looking at here, you can see how the lower tissue here is starting to tighten up around the next to the teeth. And also what we're looking at here is we're starting to get that nice orange peel appearance which we like to see in healthy gum tissue. And if you looked at this patient now, you wouldn't think he looked like what he did before when we first started the procedure. He's now in maintenance. And one thing I found, and this is anecdotal, but most people who do LANAP mention it also, patients who have LANAP are more apt to come in for regular maintenance than patients who have had traditional gum surgery because there's less sensitivity and it's a healthier environment and they don't feel like they've got all these roots showing too. So they're much more apt to stay in their maintenance programs for the long haul. Here's another patient here. If you look at his x-ray, what you can see now is he has a significant amount of bone loss. We probably classify him probably at least a class type 4, severe periodontal type of disease. Again, in a traditional periodontal office, even in a general dental office, you look at this case, throw up your hands and say, we're looking at dentures here. We might be able to save a couple of the bottom teeth, but overall dentures, implants, etc. The patients don't want to lose their teeth. They want to try to keep their teeth. So the best you could do here, if you want to try to keep the teeth, is scale and replanning. But again, with pocket depths greater than 6 millimeters, scale and replanning has very little effect. Here's what the patient looked like clinically upon presentation, and what you can see here now is you can see how red and inflamed the gingiva margins are. He really hasn't lost a lot of gum tissue. That's how we get deep pockets. If the gum doesn't follow the bone, we get our deep pocket depths. So, and you can also see right here, you can see just by even just blowing air on this patient, he was just bleeding. We went ahead, did full mouth LANAP treatment on him. We went ahead, stabilized these bottom teeth here because we want stability so we can get nice new connective tissue attachment and any bone growth that we can accomplish in vertical defects. And this is what he looked like 4 weeks later. Now that is a major significant change Patient's not having any more discomfort. He's not bleeding when he brushes. And you can see just how nice that nice orange rind appearance that we're getting around these teeth. It's very maintainable. He's got a little problem. He's got to use a little proxy brush a little more. But basically, in my estimation, we've probably kept his teeth. And if he wanted to have orthodontics done to kind of bring these teeth together, I would have no problem with that. But basically, this patient's on the road to recovery.